Okay. Are you able to see my screen?
We all nodded. I don't know if you have us
Oh,
up. Yes.
okay.
Yes, we
No,
can.
everybody disappeared when I turned on my screen recording.
We muted and then we nodded. So I thought I
Okay.
better tell you, but we could. Yes, we can.
Okay, just making sure. Okay, so my name is Leslie Croft. I'm doing my capstone project over alarm fatigue. I'm currently a stay-at-home mom, so the unit that I'm using as an example is my previous place of employment. It's a med-surg floor that recently got switched to a step-down unit just a few months before I went on maternity leave because we closed our critical care. So it's a little bit of both, but I have experience in med-surg, a COVID unit, and then some in a step-down unit as well. So this is my capstone project. Within this presentation, there's going to be the workplace problem, the literature review, a PICO question, a recommendation for the evidence-based practice, and then the post-presentation discussion. So the problem that's being addressed is alarm fatigue in nurses. The population that it's referring to is the adult and geriatric patients admitted to a step-down unit. And according to the US National Library of Medicine, alarm fatigue is a sensory overload where clinicians are exposed to an excessive number of alarms, which can result in becoming desensitized to the alarms and missed alarms. And the amount of false alarms that go off during shift is around 85 to 99%, according to the US National Library of Medicine. The negative patient outcomes can result to poor patient care. Nurses are taking longer to answer the call lights, bathroom alarms due to the alarm fatigue. These call lights will go off and the nurses are just so used to hearing it. They just completely space that it's an alarm going off or a call light that they need to go assist their patient. And then it can create a negative hospital experience for those patients. The patients are waiting longer to get help, so they just get up. They will go to the bathroom without calling anybody. They just get tired of it. And then another thing, when I would come in on the day and on day shift, the patients would mostly complain that there was alarms going off all night long. They weren't able to sleep. They weren't able to rest. They're exhausted. They're just tired of hearing it. And a lot of them wanted to just leave AMA because they were just over the whole hospital experience. And then the last one is patient safety is at risk. Like I said before, nurses are just starting to ignore the call lights and fall alarms that are going off. And prior to me going on maternity leave, we actually had 2 patient falls because nurses just completely spaced that it was the fall alarm going off. And by the time they had gotten into the room, the patient was already on the floor crying out for help. They were scared. They didn't know what was happening. So the patient safety is really at risk here. So this section of the PowerPoint is going to go over the literature review. It's the 5 studies that I found to support decreasing alarm fatigue. The first study is an evidence-based approach to reducing cardiac telemetry alarm fatigue. The purpose of this study is to determine if regulating and adjusting alarm parameters would decrease the amount of alarm fatigue nurses were experiencing. The intervention that was used was regulating and adjusting alarm parameters to avoid an excessive number of unnecessary alarms going off. So an example of this is when a patient has a tele on, if their heart rate usually runs in the 50s, then that nurse should make their tele go off when their heart rate goes like around 45 instead of going off when their heart rate goes to 55, because that's just an unnecessary alarm, especially if that's normal for the patient for their heart rate to run that low. This was done in an acute care hospital in Boston on a surgical telemetry unit. The sample size that used in the study was data collected from September of 2013 to November of 2013. And the study showed that after implementing the intervention, there was a 54% decrease rate in the alarms that went off per bed per day. The second study was research outcome of implementing the CEASE. The purpose of this study was to find a solution to help nurses not experience alarm fatigue during their shift using this model. So like I said, the intervention was implementing the CEASE, and this stands for Communication, Electrodes, Appropriateness, Setup Alarms, and Education. And what that means is the communication means to communicate more effectively with your colleagues, let them know what's going on with your patients. The electrodes means to change out the electrodes daily and ensure the leads are placed correctly on the patients. The appropriate means to ensure appropriate steps are being taken and to ensure that the orders are placed, because a lot of the times patients will get an order for tele or a verbal order from the doctors to be placed on tele. The nurses will place them on tele, and then their alarm just keeps beeping and beeping and beeping because they haven't actually been put in the system on tele. So it just keeps beeping to tell us that that somebody's on tele. We don't know who. Somebody needs to figure out, and a lot of nurses just ignore that because they're so used to alarms going off. And then the setup means to personalize the alarm sounds and parameters to the patient. That kind of goes back to, if the patient normally runs in the 50s with their heart rate, then you need to adjust that alarms or the parameters to go off at 45 rather than 55, especially if that's normal for the patient. And then the education part is just to educate nurses on the monitoring system so they know how to change the parameters and they know how to make it specific for their patients. This was done in an acute care hospital in the United States. The sample size for the study is how many alarms that went off during a 6-month period. And by using this intervention, it helped decrease the number of unnecessary alarms from 68% to 44%, and it had a decrease in the nuisance alarm, which is P equals 0.0417 after the intervention was put into effect. The third study is alarm-related workload and default and modified alarm settings and relationships between alarm workload. So the purpose of this study was to determine the effect that alarms have on nurses' workload and how to help solve this alarm fatigue. Then the intervention in this study was to modify the alarm setting and the alarm tone to personalize the alarm to the current patient. It was done in a progressive step-down unit in the United States. And there were 30 total participants, 23 are females and 7 of them were males. And by using this intervention, it showed that the workload was lower when using the modified settings, or P is less than 0.05. The fourth study is the effects of monitor alarm management training on nurses' alarm fatigue. The purpose of this was to find a solution to decrease the alarm fatigue in nurses in order to increase patient safety by prioritizing alarm management. The intervention used in this study was having nurses attend a 12-week course on alarm management. It was done on a critical care unit in the acute care hospital in China. So there are 68 nurses that work on a critical care unit that were involved in this study. And the results were the alarm fatigue scores in the experiment group were lower than the alarm fatigue scores in the control group. It was P is less than 0.001. And the fifth study is the team-based intervention to reduce the impact of non-actionable alarms in an adult intensive care unit. So the purpose of this study was to find a way to decrease the number of unnecessary alarms that go off in a critical care unit by implementing a team-based alarm management approach. And like I said, the intervention was the team-based approach. So what this is a team of nurses and other healthcare providers like the CNAs, the doctors, they all get together and they kind of look at all these studies and try to find a way to determine the best way to decrease the alarm fatigue in their healthcare workers on their unit. They just find a way that works best for their unit because every unit is so different. This was done on a critical care unit in the United States, and the total sample size was alarms that went off in the unit of 2015. And the results showed a 40% decrease in the number of alarms that went off after the intervention was implemented. Next, we're going to go over the PICO questions. So the P in PICO stands for population. The I is intervention, the C is comparison, and the O is outcome. So the PICO question that I was able to form through this course was, in patients admitted to a step-down unit, how does adjusting alarm settings compared to standard alarm settings, which is the current practice, affect the number of alarms and alarm fatigue? The population, like I stated before, is adults and geriatric patients admitted to a step-down unit. And the current practice at my facility is just leaving the alarms and the devices at whatever the standard settings, whatever was previous. Nurses are really bad about adjusting these to their patients. So this is a major issue because it's just causing a lot of unnecessary alarms to go off during the shift. One intervention that I think has been successful and would really work on my unit is regulating and adjusting the alarm parameters, making sure that every device you pull for a patient is adjusted to that patient and specific for that patient. So that way we can decrease these unnecessary alarms. And then another intervention that I think would really work in my unit and has been really good at decreasing the alarm fatigue is having nurses attend an alarm management course for 12 weeks. So what I think would work well is to do one class a week for 12 weeks. These classes range from 30 minutes to an hour, offering multiple time slots to accommodate both day shift and night shift. And then the educational officer at my facility and then the nursing manager would teach these classes. These are the two people that usually take on all education at my hospital anyways. So that this would fall under their kind of job responsibilities. So they would give visual demonstrations for nurses on how to change like pump alarms, how to change their telemetry alarms, and allow the nurses to just do a lot of hands-on practicing so they can practice outside of being in the presence of a patient and know how to change these alarms and modify it to the patients. And then after they do the initial 12-week course, then we'll just have this like a mandatory yearly continuing education, kind of like we call them health streams at my facility. So it's just once a year you have to go over education that is important for the facility that you work at. And I think this would be beneficial just to keep a refresher on the alarm management. And then a recommendation for evidence-based practice. So an appropriate process to implementing the above interventions would be the PDSA model. The PDSA stands for Plan, Do, Study, and Act. So the first step is to plan and propose an idea on how it will be tested. And one way to do this is attend the monthly staff meeting and bring this idea forward to my nursing manager, who does a lot with implementing new practices in our facility. Then the second step is to do the intervention and implement it into the current practice and collect data on the intervention. So this can be done by having the training done on the interventions, having the nurses start the 12-week course so they can start learning about their devices and how to manage their alarms. And then how to collect data, which is part of the third step, is to study and analyze the data collected. We can use our telemetry devices. They automatically collect all of the alarms anyways that go off. Anytime the tele goes off, it's collecting whatever data and saving it to a database that we have. And another way we can do collect the data is by looking at the call lights. I think that right now the nurses take a long time in my facility to respond to call lights. And I think a lot of that has to do because they're just so tired of the alarms going off. They just kind of ignore them. And they space the fact that their patient's calling and needs something. So I think if we take the data prior to the interventions being implemented and then compare it to the call lights after the interventions being implemented, I think that's a good way to kind of see if the alarm fatigue is getting better or not by if the nurses are responding quicker to their patients. And then the fourth step is to act and decide if the interventions implemented were effective or not on improving the workplace problem. So this is again just by comparing the data collected, looking at different aspects like the call lights going off and how quickly the staff respond to them, or looking at the telemetry devices to see how many unnecessary alarms go off, and then how to measure the outcome. This is, like I said, comparing the number of alarms that went off prior to the intervention being implemented and after the intervention. Another idea is to have nurses take a survey prior to the interventions about alarm fatigue, how they feel, what they think is a big issue, and then take that same survey after the interventions have been implemented to see if anything's changed, if they think it's gotten better. And then you could have patients that are admitted to the hospital. They already get patient satisfaction surveys, so we could include a survey there about the alarms and see what they think, how the alarms are prior to the interventions being implemented and then after the interventions are implemented. So here's the post discussion part. I kind of want to see what you guys think about this. Do you guys think that the intervention is appropriate for the workplace?
Certainly, I think that your intervention would be good. I think that, the question will be the buy-in from the institution about the training sessions and the cost of having people, off the unit for that amount. I think that your sell is going to be the patient safety data that you can provide for them. And so that would be an important part of that, getting them on board with that, I think. maybe making that, things recorded where they could watch a piece of it here and there rather than be off the unit.
Mhm.
So, maybe that 30 minutes might be broken down to where you can watch, maybe I have 10 minutes, I'll watch 10 minutes of it tonight and catch another 5 minutes the next night or whatever it happens to be. How that is depends on how busy your unit is.
And that's
Yeah,
exactly what I was going to say as well, that I think if you could put this into a module format, there might be more buy-in where they can work on it a little on their own time, of
Mhm.
course, with possibly deadlines so that they can stay on track. And I think you also have to get buy-in from education, since they're the ones that we are hoping would be implementing the education itself.
Yeah, definitely. And a really awesome thing at my facility is we're allowed up to 16 education hours outside of the workplace. So we can bring home, they'll give us a laptop to take home and we can work on it at home and they'll pay us. They don't even take track of they just tell us, hey, let me know whenever you guys worked, what times you worked from, and I'll put it in and you can get paid for it. So I think that's pretty awesome. That would help a lot.
That would make that ideal. Yeah.
Mhm.
Mhm. So do you think how will this intervention positively or negatively impact the nurse's obligation to provide the holistic, culturally sensitive, and patient-centered care? Do you think that, I personally think that it'll be positive. It allow nurses to be more focused on their patients. Because right now, like I said before, when a patient calls, if you look around, you'll see just the nurse standing there, not doing anything, but you can tell she literally does not notice that alarm's going off. They're so exhausted from the alarms that they're just like, oh, whatever. And then finally, after a few minutes, it's like, oh, shoot, my patient's calling me. And then they're running, trying to apologize to the patient. So I don't know if you guys feel that way too. What are your
And
ideas?
I think you make a great point. It's not intentional. It's not that they mean to ignore the alarms, but I do think that your interventions are definitely going to be patient centered.
Mhm.
We can start being able to refocus on our patients because we're not having all that extra oh, extra information coming in that we have to sift through. So
Okay. What are the legal and
Hey,
ethical?
Leslie,
Yep.
I think Dr. Veek had something to say.
Oh, I'm so sorry. I didn't see you.
That's okay.
I was just going to tag, I don't know if this is related to the intervention or not, but one thing to consider is that some cultures and some groups may be more hesitant to hit an alarm and only do it when it's something really critical. And so making sure that people are aware that, if this room number alarm or bed, call button is hit, they might need to really hit them first if they've got
Mhm.
two going off, because that person may wait until, pain is severe before they call for, pain meds, or, there are just different cultural groups that are going to be less likely to be on that button all the time.
Mhm.
Yeah, and in my area, we have a lot of the Amish community,
Mhm.
and I think when they get admitted to our unit, there are nurses they kind of keep an eye on their call lights because we know that they're not going to call unless they absolutely need us in their room. So
Yeah,
that is something that I notice now, but still, if they call, you will still see their light go on for at least 5 minutes, just because the
right,
nurses and CNAs, they don't realize that that's the alarm going off. They're just so
right.
used to every alarm going off. It's like you have PTSD when you get home at night. You go to lay down in bed and you hear the alarms going off still in your head, and you're like, oh my gosh, who's
Yeah,
calling me now? Even though you're about to go to sleep.
sure.
And considering the holistic aspects, since we're touching on the other two, you brought up yourself that you would come in the morning and they said they didn't sleep at all last night because the alarms were going off, and
Mhm.
that we know that rest is so important as they're trying to heal. So helping with that, with these interventions that could again apply to the whole patient.
Yeah, I think it would make the patients happier because a
Mhm.
lot of the time they're just so angry when we get in the morning because we come in, hey, good morning, how are you doing? And they're like, don't talk to me. I didn't get sleep last night. Your guys' alarms woke me up all night. So I think it would really help that like nurse patient relationship as well, make the patients a little bit happier. Okay, so what do you think the legal and ethical implications for the nurses will be when implementing the intervention?
Well, thinking legally, if we are improving patient outcomes with an intervention, if we're preventing falls, we're hopefully limiting the legal implications by implementing these changes. So, definitely a positive.
Yeah, that's what I was thinking, because with the legal part, with those 2 falls we had, the patients had to go get a CT scan of almost their whole body because they fell just walking into the bathroom, and one actually got wedged in between the toilet because they tried to catch themselves. And it was so awful. And I mean, of course, that nurse felt terrible because they heard the bathroom alarm was going off, but they're just so exhausted with the alarms that it didn't even register that, oh my gosh, my patient's bathroom alarm's going off. And then the other one, the patient got out of the bed and it was the fall risk. The bed alarms, all the alarms were set in place. They went off and nobody responded like they should have. So I think legally it will cover the hospital's butt too. It might cost them a little bit with the education part, but in the long run, it's going to save them because they're not going to be paying for patients to get all these extra scans done, because that's on us at that point.
There may also be some implications for staffing. You may find that even, with dealing with the alarm fatigue, there's not enough staff to quickly answer the call lights. So that may have some other legal implications. What if you find out that more staffing is needed? Then what does that do if the hospital finds out they know they have to have more staffing? They don't address more staffing, let's say, and they're going to be, legally out there because they've identified that need and yet haven't responded to it. So they have to be ready to respond to that if that is an issue, if staffing is part of the issue.
Yeah, and I think staffing's an issue everywhere right now, especially since COVID has hit. I've personally seen a lot of nurses leave healthcare altogether and just go to a different profession because they're just so exhausted, they're burnout, they're tired of it. So staffing's definitely a huge issue that goes along with it.
Absolutely.
Another thing I'm thinking about legally, sorry, I know you were getting ready to
change.
You're
okay.
Is that education would have to be well documented, because if you are changing the settings on the alarms, and then there was an injury and they fell within what you had set, like the alarm hadn't gone off because you had lowered the alarm setting, we'll say the heart rate, and then there was a negative outcome for that patient, then there has to be good documentation of why that was set in that way, or you as the nurse, I think there would be some legal implications.
Oh yeah, that's definitely something to think about. And a good thing at my employment is they keep track of all the education that we do online. They have like their own they call them health streams, and we have to do them yearly. There's like 20 to 30 health streams that we get. It goes over like the strokes, starting IVs, how to do it's a lot of education, and they keep track of all of that. And if you don't get it done, there's somebody like our educational officer, she is on your butt. Hey, you have a day and a half to get this done. If you don't get it done, you can't come to work until it's done. Like, they are on you, which is really good about my hospital. They're on you to get your education done, so they can keep track of it too. It helps cover them also. So then the next one is, how will implementing the intervention positively and or negatively impact the interprofessional team, such as like workload, job satisfaction, ability to provide self-care, and ability to participate in the evidence-based practice?
I think if the alarm fatigue does go down, if it decreases, I would think that would lead to improved job satisfaction.
Oh yeah, definitely. Yeah, I actually know a few nurses that have left. One of our medical assistants just left to be a dog groomer because she was so tired of everything. She texted me the other day and she's like, oh my gosh, I don't go home at night. I don't have those alarms buzzing in my head. She's just so much happier with her life now that she's out of like a healthcare setting, having alarms going off.
And that would decrease workload too, right? I mean, if you're
Oh,
not
yeah.
running to alarms constantly to turn them off, would you say 85 to almost 100% of alarms are false? That was an insane number.
Yeah.
Just thinking of all the time we would be spending running to turn alarms off or checking on that patient constantly.
Mhm.
Yeah.
Something, Leslie, that we didn't talk about during your rehearsal, but this has come up with other students when they've had this topic was, let's say that I'm like the day nurse and I feel comfortable setting these parameters for this patient. And you're the night nurse and you don't feel comfortable with these parameters. How do I communicate my parameters to you? And how do you feel comfortable changing them from what I've set? Does that make sense?
Yeah.
Like having that good communication between,
Yeah,
you know,
because the
patient
night
and
nurse, the night nurse is definitely going to be more comfortable with setting a lower heart rate because
Probably,
that
right.
is going to go down.
Right, or not, depending on like her or his or her just, you know,
Yeah,
experience and
yeah.
level, and maybe something's happened during the day that whatever. Just making sure that there's good communication between, you know, caregivers
Yeah.
about the parameters.
Yeah. And another
didn't
thing
talk
is, with Epic, you're allowed to, at least the Epic that we use, you can put an order in for the alarm parameters. Nobody uses it right now, but
Wow.
you can put in there set telemetry alarm parameters from 50 to 80. And one of our providers uses that a lot. Now there's a lot of nurses that don't actually change it, but there is, if you look through like patient orders, when he's on, he'll set like he wants his alarm parameters from here to here. And then you can go and talk to him about it, be like, hey, I don't really feel comfortable with this. What do you think about changing it? But like I said, a lot of times that order just gets skipped over, and I don't really know why people just kind of just miss that or ignore it. But I think
Or leave it to the bedside nurse to decide or whatever.
Yeah.
Yeah.
So that needs to be part of your education.
Mhm.
Mhm.
Yeah, looking at the orders and making sure you're actually doing what the provider wants. So the next question is, what is the workplace's process for implementing the intervention? I know this is kind of hard for you guys to answer since you don't know my workplace, but at my workplace, we don't have any process that I'm aware of. Like we just switched over to Epic last year and there was no like PDSA cycle. There was no implementing anything. It was just, hey, this is what we're doing. You have 1 or 2 courses over it. And then we switch in a month. So it was just thrown at us. And that's kind of how they do everything. They just throw it at us. They don't really give us any warning. And so it really makes a lot of nurses mad, especially like the older nurses that we have. They don't like to change. They don't like to do. They are stuck in their ways. I'm dead set that they would still be paper charting if they're allowed to. So
Are you a magnet facility?
no, we're not.
Not on the magnet journey at all.
Not that I'm aware of.
That would, that would be part of that because you would have a research team then if you had that. And so that could be something that you could consider. It may not have to be a full-blown research team, but maybe a committee that works on a process.
Yeah, I think that definitely needs to be at least at my hospital because there's a lot of things where they just throw at us and they're like, here, this is what's happening. Like the switch from a critical care to changing the med surg into a step down unit. That was something that happened within 2 weeks of our CEO deciding that. And it was a big mess. And there was a lot of patients that their safety was put in harm. We had a lot of patients crash and burn when we did that because nobody knew what was going on. They got rid of our intensivist. They got rid of the person who intubates when we need somebody to intubate if a patient codes. So it was something that they just threw at us without really giving us any time to prepare. And that's what they do, fortunately, at my hospital. So I think there needs to be a better process. I think the PDSA is a really good cycle to use.
Have you seen that they do? Oh, I'm sorry.
No, you can go ahead.
I was just going to ask, do you see that they do pilot studies? Like they say, hey, we're going to implement this. We're going to pilot it on this unit, and then we'll see how it goes. And then we'll implement it on the other units if it goes well.
Before they shut down our critical care, med surg was kind of their lab rat is what they like to call us. they would throw everything at us. And then, oh yeah, if it works good, then we have a sister hospital about an hour away from us. It's way, way bigger than us. So they would throw everything at us, see how it works on our unit. And then if it works well, great, we're going to go do it at our bigger hospital. But if not, well, that's okay. You guys are small and it doesn't really affect that many people. So yeah.
Right. That really adds to the morale of that floor, I'm sure.
Yeah.
We're expendable.
Yes.
Are our patients. Yeah. Yeah. Wow. Talk about a morale buster.
I know, right?
Especially if you don't have input into the process and how it's going to be rolled out on that floor. Now, if you guys had input into it, then, we're going to be the ones who get to try something new and we have input into it. I mean, it's just all in how it's approached.
Yeah. And they would ask us, oh, how do you feel like this? How do you think this went? But you could tell it was, I don't know, they weren't really taking in what we're suggesting or saying. It was, they were just letting us talk, I think, just to let us vent a little bit about however it went down.
Allowing someone to say something or making sure they're heard are two different things, aren't they?
Exactly. Yes. So what do you think are some barriers to implementing the intervention, and how can these barriers be overcome?
Well, it sounds like,
we've-
oh, go ahead. No, the first barrier is right there. You don't have a process.
Yeah.
Yeah, that's what I was going to say. Yeah.
So the process, but also the time involved in a 12-week class. I think you kind of addressed that already, saying that they have that built-in time per year. That's huge, that a lot of facilities don't offer that. As long as you will probably have some people who use that time in other ways and might already kind of have in their minds where they're going to use that, and then being told that 12 hours is now taken from that. For that year, they only have 4 hours left to do with what they want. That could be a problem, but I think that is possibly a barrier.
Yeah. And I would say that because just based on what you were just saying about this unit being the guinea pig unit for, all the changes, just one more change, getting buy-in and listening to your colleagues and how, they think that they would like to try to implement this, and doing it as here's the problem, and presenting all the data on how this can work, and then saying, approaching it as if, what do you think about, implementing these interventions, and listening and tweaking things, being flexible as you go about that in setting it up by taking in that information from the team would be important. And so there, you may find that team can help you fine tune your process, since you don't have a process, but they may be able to be a part of fine tuning that as you move forward.
Okay. The last one is, who do you think are the advocates involved in implementing the interventions, and why are these people the advocates? I personally think that the advocates would be the nurses. That's just because they're the ones mostly exhausted. The CNAs and the nurses are constantly running after these alarms. It doesn't really affect the providers that much. They're usually in on the floor and out within an hour. They see their patients and go back to their office to chart or answer messages or admit patients. So I think the big advocates would be the nurses, the CNAs, and then even patients too, because this all affects the patients also. It causes a lot of stress on patients, causes a lot of discomfort. So I think they would really be for us finding a new process to decrease all those unnecessary alarms that go off in their rooms.
I think also,
oh, go ahead.
I was just going to say that you said there was a doctor that was more specific on parameters. That might be a good person to also have in the discussion to help advocate for you.
Oh, yeah.
Yeah. You might also look at those studies in terms of turnover with alarm fatigue, and that may help bring on some more of the administration in terms of, hey, if this can reduce our turnover, then let's try this and see, because we're tired of people leaving and reorienting, that is costly. I mean, that
Yeah.
costs the facility. So you might be able to get some support in an unlikely place just because of funding. You got to look at the funding aspect.
Yeah. Well, that's all I have, and here are my references that I used. I just want to say thank you guys for helping me and listening and joining in on my post discussion. I really appreciate it.
Thank
Sure.
you.
Yeah, thanks. It's interesting. Thank you.
Yeah. Good job, Leslie.
Thank you.
Do you have any questions for us before you log out?
I don't. The only question I have is the sign-in sheet.
You just put our names down.
Okay, perfect.
That's fine. Mhm. All right.
Okay,
Okay,
thank you.
thank you.
Thanks.
Thanks.
Bye-bye.
Talk to you later.